I know I'm the final talk on a Friday afternoon, so I'm going to try to keep this peppy. But what I'd like to really use this final closing talk to discuss is how we might use real-world data to help us examine why and how care often breaks down after an APO, and where the opportunities might be for us to intervene. So with that, I will go ahead and get started. These are my disclosures. So we have heard from many of our speakers today, and much of the field has already established that adverse pregnancy outcomes are associated with later life cardiovascular disease. And that's been a theme that's been echoed across the symposium today. So, well, the question I want to ask all of us to consider together is, well, if we know that APOs matter, why hasn't that knowledge changed care? For example, we know adverse pregnancy outcomes, preeclampsia, gestational diabetes, stillbirth, et cetera, are early signals of future cardiovascular disease risk. And yet, that signal doesn't necessarily prompt structured postpartum follow-up, transition into prevention, and certainly doesn't prompt long-term cardiovascular care. So I'd like to consider a case together to help frame our discussion. This is a 32-year-old woman, G2P1. She has a history of obesity, gestational diabetes, and a prior pregnancy. And she's pregnant again. She's done pretty well this pregnancy until about late third trimester, when she develops preeclampsia at 38 weeks. So the decision is made to induce her, and she's induced, undergoes an uncomplicated vaginal delivery, does pretty well, a little bit hypertensive after delivery, so she's continued on antihypertensive therapy and then discharged home 48 hours postpartum. Unfortunately, 8 days later, she is readmitted with pulmonary edema, orthopnea, lower extremity edema, all the telltale signs of a heart failure presentation. She's given IV diuretics, and her antihypertensive therapy is escalated, and then she's discharged. Now, fast forward 6 months. She's still hypertensive, she's still on antihypertensive therapy, and not surprising to any of us here, there's been no plan to establish long-term cardiovascular care prevention. So I think this is a really pivotal moment, right? Our patient has already shown us that she's at greater risk for cardiovascular disease. She has obesity, she's had a history of gestational diabetes, now preeclampsia. She had a postpartum heart failure presentation, and then now has gone on to develop chronic hypertension. So if we do nothing, I think we all know how this story progresses. Over the following subsequent years, she will develop and accumulate more and more cardiometabolic disease on top of what she already has. And then 25 years later, she comes in with an acute myocardial infarction. So I think what I'd love for us to consider together today is, what has been echoed, I think by Michelle, Nisha, others, is that pregnancy is not an isolated obstetrics event, but really often the first early window into cardiovascular health. We've talked about this already, so I won't belabor it, but APOs really represent early manifestations of vascular and metabolic vulnerability. We have all know that pregnancy places substantial physiologic stress on our cardiovascular system, and if that stress reveals underlying vulnerability like insulin resistance, hypertension, maladaptive vascular remodeling, and inflammation, that can often manifest as an adverse pregnancy outcome. And these really are the early markers or early signals of adverse cardiovascular events later on. And that has been substantiated by our epidemiology. That's really supported this framework. A number of large cohort studies have shown us that adverse pregnancy outcomes are associated with later life cardiovascular disease, even after adjustment for traditional cardiovascular risk factors. And these are analyses that Nisha had already shown us that she had led with her trainees that basically looked at an analysis of 50,000 women in the Women's Health Initiative that showed us that adverse pregnancy outcomes like gestational diabetes, low birth weight, preterm delivery, and hypertensive disorders of pregnancy were all independently associated with later life atherosclerotic cardiovascular disease. And then when all the APOs were put into a single model, low birth weight and HDP were still independently associated with later life ASCVD. So I think the unmet need here is not have we established the link between adverse pregnancy outcomes and cardiovascular disease. It's how do we take that knowledge and translate that into improved prevention and care. And that's where I think real-world data come in. If we really want to move beyond association and try to figure out where our care pathways are breaking down, I argue that real-world data are really essential for helping us study pregnancy at scale. And that's because it enables us to study large and diverse populations, allows us to longitudinally follow patients across their pregnancy continuum, and can help us identify care gaps and missed prevention opportunities. But the problem is that pregnancy is really hard to study in real-world data. For one, as we all know, pregnancy care is often fragmented across systems. The other issue is that pregnancy timing is very difficult to define, especially in the electronic health record, in large part because gestational age data are often missing. And then if we rely on diagnostic or billing codes alone, we often are challenged by misclassification of outcomes. And so this is why we built a scalable real-world pregnancy electronic health record cohort within the Mass General Brigham system. And we affectionately named this cohort Padme, named after Luke Skywalker and Princess Leia's mother, who famously died in childbirth. And I'll tell you a little bit about how the Star Wars theme started in just a moment. But essentially, we wanted to overcome some of those limitations I just talked to you about. And the way we did that is first we identified pregnancies within the primary care population. And it's actually this primary care electronic health record cohort that started this whole Star Wars theme. So that primary care cohort is called C3PO, or the community care cohort. And it was important that we anchored the pregnancies to C3PO because if we only looked at isolated obstetric encounters, what we risk doing is capturing pregnancies among women who deliver at Mass General Brigham, but then get the rest of their longitudinal care elsewhere, which is really often the case. So by identifying pregnancies within an established primary care cohort that's receiving longitudinal care at Mass General Brigham, we're able to ensure generally stable longitudinal denominator of pregnancies. And then the second thing we did is that we used machine learning approaches to help recover missing data, like vital signs and pregnancy-related features, including gestational age. And these are features that are infrequently captured by diagnostic codes and tabular data. And then finally, rigorous ascertainment of outcomes was part of our workflow. I mentioned that one of the biggest biases of real-world data, including electronic health record data and large claims databases, is misclassification of outcomes. So rather than taking diagnostic codes at their face value, we applied validated algorithms to help define disease outcomes. And then we confirmed the accuracy of those algorithms to ensure that, that we were capturing what we thought was reasonably high fidelity disease outcomes. And putting that all together, our final Padme cohort comprised over 56,000 pregnancies across about 39,000 unique individuals between 2001 out to 2019. Now, one of the biggest technical barriers that I think we face when building a pregnancy electronic health record cohort is missing gestational age. So as I mentioned earlier, gestational age is rarely captured by diagnostic codes, and it's rarely seen in tabular data. So we applied regular expressions, or reg-X, to clinical notes to recover gestational age, and we were able to recover gestational age for about 74% of pregnancies. And this effectively increased the size of our usable sample from about 21,000 pregnancies up to over 56,000 pregnancies. Now, of course, it's not just enough to recover the data. We need to be sure that the data are accurate. And so panel C here displays a correlation between gestational age ascertained by manual adjudication on the x-axis and that obtained through the reg-X approach on the y-axis. Sorry, there's a little formatting issue here. But I think you can see overall here that the reg-X approach actually showed strong correlation compared with manual adjudication. And then panel D displays a Bland-Altman plot that shows us that the regex approach did not have a tendency to either overestimate or underestimate gestational age compared with manual adjudication. So I think these data gave us confidence that we were able to capture gestational age at scale without sacrificing accuracy. And one of the first lessons we learned from our real-world data is that our pregnant population is changing. The prevalence of maternal cardiometabolic disease, including obesity, hypertension, hyperlipidemia, and diabetes, all increased over the study period from 2001 to 2019. So essentially, women are entering pregnancy with a greater burden of cardiometabolic disease than now than they were 20 years ago. We also found that pre-existing maternal cardiovascular disease is also increasing. So as you can see here, that the prevalence of pre-existing maternal cardiovascular disease nearly doubled between 2001 to 2019, reaching 11% among women who are age 40 or older. So we're seeing that pregnancies are increasingly occurring in the context of cardiometabolic disease, but also among women with established cardiovascular disease. And this has really major implications for counseling, surveillance, and postpartum follow-up. And finally, in parallel, what we're seeing is that pregnancy-related cardiovascular complications are also rising. You can see here that by the most recent era in 2016 to 2019, nearly 1 in 4 pregnancies among women who are age 40 or over had a cardiovascular complication. So I don't think that any of these findings are necessarily surprising. I think any of us who care for patients see this day to day, but I think they're important because they highlight that at a systems level, the epidemiology are consistent. We're seeing greater burden of cardiometabolic risk, higher prevalence of established cardiovascular disease, and then in parallel, rising incidence of pregnancy-related cardiovascular complications. So I think that leads us to the next question. Well, are the tools that we have capturing this changing population? And I think the short answer is no, not really. There are a number of maternal cardiovascular disease risk assessment tools that we use in practice, including things like CARPREG-2, Zahara, the modified WHO classification scheme. And these tools are pretty good at helping to refine risk assessment, particularly among individuals with established cardiovascular disease. And they help guide preconception counseling, they help us determine the frequency of monitoring during pregnancy, and really help guide the level of care that's needed at the time of delivery and in the postpartum period. But these models have several limitations. I think importantly, they were trained on modest numbers of individuals, largely those who were seen in tertiary referral centers. So you can imagine that really limits their generalizability. And then probably more importantly, they don't account for comorbid conditions, environmental factors, and especially they're not applicable to patients with de novo or unknown cardiovascular disease, which really comprises the majority of our high-risk pregnancies today. So essentially, our existing risk scores are not capturing all the high-risk pregnancies that we are seeing in clinical real-world practice. Now, it's important for us to be able to identify high-risk patients. But the reason we want to identify high-risk patients is so that we can take action. And what we're seeing is that even when we're able to identify high-risk individuals, that doesn't always translate into implementation. And a perfect example of this is aspirin for preeclampsia prevention. Aspirin is a widely available, inexpensive therapy that has been shown with very robust clinical evidence to reduce the incidence of preeclampsia, and its use is supported by clinical guidelines. And yet, we are seeing that the uptake of aspirin in real-world practice is strikingly low. So this was an analysis that was led by one of the medical students in our group, and she looked in our own Mass General Brigham PADME cohort and found that among high-risk pregnancies, very few of these women were being prescribed aspirin. Now, certainly the rates of aspirin prescribing increased over time, and certainly you see an increase after each of the clinical guidelines were introduced. But even in 2023, fewer than 1 in 4 high-risk pregnancies received aspirin for preeclampsia prevention. So this is a huge implementation gap. And then we also looked at the types of conditions that might be associated with aspirin prescribing. And we found that not all high-risk conditions were equally triggering aspirin use in our NGB cohort. So certain high-risk factors, including things like history of preeclampsia, multifetal gestation, diabetes, and hypertension, were more likely to trigger aspirin use among individuals who were considered high risk. But by contrast, autoimmune disease and renal disease, also guideline-defined high-risk factors, were weakly associated with aspirin use. So I think what we're seeing here is that even among high-risk conditions, we're not necessarily, not all high-risk conditions are being perceived equally in clinical practice. Now, I've talked about some of the missed opportunities early in pregnancy and during pregnancy, but I argue that the postpartum window is actually one of the most key and important opportunities for prevention. And that's because the pregnancy has already revealed to us if a woman is high risk. And yet, what we're seeing time and time again is that the postpartum prevention window is often missed. And we heard this already with Megan's beautiful talk earlier. And these are data from a national analysis that looked at cardiovascular health counseling in the postpartum period. And on the x-axis, you can see year. Y-axis is cardiovascular health counseling rate per 100 individuals. And I think what we can all appreciate here is that postpartum cardiovascular health counseling is inconsistent and certainly not universal, even among women who have 2 or more cardiovascular risk factors. But I think what's most troubling about these data is the trend. You can see between 2016 to 2020, the rate of postpartum cardiovascular health counseling was declining. So here, I think, the postpartum period, Michelle said it earlier, should be we should be triggering automatic transition into prevention. And yet, what we're seeing is that even basic cardiovascular health counseling is not happening. Now, and I think this all speaks to somewhat of a deeper issue, which is that reproductive care and cardiovascular care really operate in separate silos. And I think a really good example of that disconnect is that pregnancy intention assessment is rarely performed by cardiovascular providers. And that to me is a little bit of a crazy concept, right? We all have just spent all afternoon talking about how pregnancy among women who have cardiometabolic risk or even those with established cardiovascular disease is really high risk. Well, as cardiovascular providers, should we not then be asking all of our reproductive aged patients whether they intend to become pregnant? That has major implications for our preventive strategies, our counseling, therapeutic strategies, et cetera. So we asked a simple question: how often are cardiovascular providers asking reproductive aged patients whether they intend to become pregnant? And to do this, we built a large language model, adjudication model, to essentially assess whether or not there was documentation of pregnancy intention assessment within clinical notes. And this model performed pretty well. It had an accuracy of about 97% with very high positive and negative predictive values. And I think, not surprising to all of us, but perhaps quite sobering, you can see that pregnancy intention assessment among cardiovascular providers was exceedingly low. Even in 2023, less than 30% of pregnancy encounters were happening in less than 30% of clinical encounters for reproductive aged women. So we have, I think, a lot of work to do. But I've talked about some of the missed opportunities. I think, I hope that we can think now together, well, what are the potential solutions? What are opportunities for improvement? And one potential intervention is to build scalable risk assessment tools using clinical variables that are easily captured by our electronic health record. So in work led by Amanda Joel, Valentina De Sousa, and Pedro Ribeiro, trainees in my research group, we've built a clinical risk model that helps identify pregnancies that are at high risk for developing cardiovascular complications using clinical variables that are routinely available in the electronic health record, including things like maternal age, BMI, systolic and diastolic blood pressure, hypertension medication use, gestation type, prior adverse pregnancy outcome, pre-existing comorbidity, and parity. And the model performed pretty well. The area under the curve in our internal validation set was 0.71 and was 0.75 in external validation at the Beth Israel Deaconess. Now, it's not perfect by any means, but I think it does support that we can use clinical variables to help identify high-risk pregnancies at scale. Now, one of the challenges, I would say limitations of clinical risk models like the one I just showed you, is that it largely relies on variables that we kind of all already know are associated with cardiovascular complications. So one alternative approach is to see if we might be able to incorporate, physiologic information that might be able to capture maybe orthogonal signals that are related to high-risk pregnancies. And so in work led by one of the Sarnoff fellows in our group, Logan Brown, we applied a deep learning model to 12 lead ECGs to estimate peak VO2, which is a gold standard measure of cardiorespiratory fitness. And we found that lower ECG estimated peak VO2 was associated with greater risk of pregnancy-related cardiovascular complications. And specifically what we found was that women who were in the lowest quartile of ECG estimated peak VO2 had 61% greater odds of developing a cardiovascular complication during pregnancy. So we think this work highlights the potential of AI-enabled physiologic phenotyping to help us better identify high-risk pregnancies. I just showed you earlier that pregnancy intention assessment is not happening in cardiovascular clinics. So how can we change that? And that was really the motivation for this study, the PregCard trial, which is a single-site randomized trial testing whether an electronic health record alert can meaningfully improve pregnancy intention assessment among cardiovascular providers. And this alert is designed to trigger for reproductive aged women who have no documented history of hysterectomy, bilateral oophorectomy, or menopause. And it prompts the provider to ask a simple question. Do you think you would like to become pregnant in the future? And what I like about this model is that it's very pragmatic. We're not asking to build a new clinic or even asking for providers to remember something new. There's so many things that a clinician has to juggle nowadays. But it does just embed this prompt at the point of care. And I think we will hopefully see the results later in the fall, but I think it also really is an opportunity for us to think about how can we actually leverage the tools that we use in day-to-day practice to improve care delivery. So as I close, I wanted to get us back to that original case and ask us all to consider, well, what could have happened differently for our patient? And might her outcome have been different? Well, I think there are many opportunities for prevention along the pregnancy continuum. The first window is certainly in early pregnancy or even before pregnancy. We talked about how we might be able to develop better risk assessment tools. And then among high-risk patients, what can we do to ensure that we close the implementation gap for evidence-based therapies like aspirin? And then the next window really gets into that early postpartum period. That postpartum period is a critically underused opportunity for prevention. We need to be thinking about how we can develop intentional strategies that trigger automatic transitions from that postpartum period into long-term prevention and cardiovascular care. And then finally, that transition to long-term prevention really isn't happening. So when our patient developed persistent hypertension at 6 months postpartum, she should, I think, have automatically been pushed into a prevention pathway that really wasn't happening and still not happening in cardiovascular care. And so I think what this case highlights to me is that we all, and I certainly know everyone in this room knows that pregnancy is not an isolated obstetrics event. We need to help others recognize and change the framework that pregnancy really is that first early window into cardiovascular risk, and it's an early signal for cardiovascular risk, and probably most importantly, it's a really critically underused opportunity for prevention. So in closing, I just wanted to end with a few take-home messages. We talked a lot today about how APOs are early warning signs of future cardiovascular disease risk. And so much of that work has actually been done by the very individuals in this room today. We also talked about how real-world data show us that there is a growing burden of maternal cardiometabolic disease, cardiovascular disease, and in parallel, incidence of cardiovascular complications. So pregnant women are entering pregnancy less healthy, and as a result, we're seeing a lot more complications and morbidity associated with that. And finally, I think the major gap we're seeing today is implementation. It's not just about awareness. It's not, I mean, certainly there's still so much science to do, but we know a lot already, and we need to be able to try to translate that into improved care for our patients. So finally, I just want to acknowledge the tremendous team that I get to work with. I think all of us are here because we are passionate about this work, and we love to work with great people and teams, and just so thrilled to be part of this symposium today. Thanks so much.